Assalamualaikum. So the topic of this talk is Individualizing Medication Management in Chronic Kidney Disease Patients. This is the brief overview of what I will talk about in this session. So I'll give you a brief introduction and then go on to the three main areas of research that we've done among chronic kidney disease patients, and I'll end it with a short conclusion. Right, so chronic kidney disease patients have multiple comorbidities and therefore have multiple complex and complicated medication. They take medications long term to slow disease progression, and on average, a person with CKD can take 6 to 12 medications or 6 to 12 types of medications, and this can actually translate to about more than 20 pills per day. And because of this, adherence can be very difficult to achieve, and in general, when you look at adherence rates in patients with severe disease, it ranges between 3 to 80%, and really this depends on how you're actually assessing that particular patient and at which point in time you're actually assessing this patient. There's also limitations to some methods of calculating adherence, because most of these methods actually look into an overview of or a general perception of how you're taking all your medications at any one time, and it sometimes may depend on whether or not you remember what you've missed taking within the past week or month. So adherence rates, because of this, in studies may differ quite significantly. So these are the types of or classes of medications that we often see in CKD patients. Some may take one or two, some may take more than those listed here, some may take all of those listed here. So it really depends on how severe the comorbidities are present in that particular CKD patient. And the complexity of these medications is not just a type. It's also because some patients have to take certain medications in the morning, some can only be taken at night before bed. There are oral medications, there are injections that have to be adhered to, and you're not even yet looking at the frequency. Some patients are taking this on a daily basis, some taking more than 2 or 3 times a day, and so this does become quite overwhelming for the patients. So if we don't actually manage CKD patients well, the outcome of the patient will obviously be affected. So this is just an example of 2 patients, CKD patients, and their medications. The first one at the top is on stage 3, whilst the bottom here is a patient on stage 4. So you can see there's both patients are actually taking quite a long list of medication, and just imagine the patient having to take these medications home and having to sort them out and making sure that they're adherent to it. So if you were to assess this patient's adherence and you're assessing it as a general intake of medication, you wouldn't be able to really understand which drug they're not adherent to and which drugs are actually causing the problem. So there's actually a need to look into each specific drug and identifying which drug they're not adherent to, so that specific interventions can be done to this patient. And medication complexity is an issue in patients, and this is even more so important for patients with CKD. And as you can see with the graph here, complexity of the medications increase. You can see that the rate adherence tend to decrease quite significantly. So from 80% adherent on a once daily drug to only just about 50% adherent to a drug that's given 4 times a day. So the complexity of the medication is something that should be looked into and adjusted accordingly if it is possible. And if you take this into account, in CKD patients are taking drugs that are OD, BD, TDS. The mixture of this can cause even further confusion to the patient, which could reduce adherence rates among them as well. Another important issue is how adherent are they over time? There's not that many studies out there that actually detect how adherent patients are over a time period, which is something I think should be done, especially among CKD patients, looking at the complexity of drugs that they're taking. So the persistence of drugs tend to decrease, and this study in particular among cardiovascular patients has shown that persistent use of drugs decline over 2 years, and they've shown here quite nicely that doesn't matter what drug you're on, the persistence of drug seems to decline quite significantly in a similar way for all three graphs, for all the 3 different groups of drugs that they're looking into. And some of these factors are advanced age, comorbidity, and just good self-perceived health, which can also occur in CKD patients because you may not feel like that there's anything wrong with you, and this might cause these patients to actually stop taking the drug. So adherence in this case should actually be monitored over time and should be addressed and identified over time as well. So it shouldn't just be a one point in time assessment. It should be done continuously, regardless of whether the patient says they're adherent, to ensure that there's persistence in taking that drug. So another thing you have to take note of is that as the stages of CKD increases over time, as patients' renal function declines, what happens is you usually have a lot more medications that the patient has to take. So there's always adjustments and changes to medications in CKD patients as you move from one stage to another. So there's an important need to actually reduce complexity. We've already seen the 2 patients in the previous slides and their list of medications. Taking into account that this changes every so often, one of the things you have to take into account when it comes to actually addressing CKD patients' medication is that you want to reduce complexity as much as possible. This is because you have to improve their adherence, make sure that there's persistence in drug taking. You've got to constantly manage the changes that occur with a CKD patient's medication. And one of the things that is upcoming right now is actually look into the possible effects of pharmacogenetics. So this is something that's quite interesting to see that we've also done studies on, and we'll talk about that in a bit. And all these have to be addressed to ensure that you optimize the outcome of patients with CKD. One way to do this to optimize outcome is through individualized medicine, which is actually tailoring that particular patient's medicine based on their lifestyle, environment, and genetics, which is why I mentioned pharmacogenetics just now. So this is actually a shift from choosing a treatment based on a group therapeutic efficacy, which causes pitfalls such as, there's a lot of complexity, questions towards adherence, there may be changes towards medications during that time, effects of adherence through ADR, and the person's own genetic effects. These are the things that may cause clinical outcome to not become optimized, and so one of the ways to overcome this is actually through individualizing treatment based on the patient's response to that particular drug. So moving forward, what needs to be done is actually identifying what sort of patient factors may affect patient clinical outcome. So the first study we did was actually very simple. We wanted to look at how adherent patients were to each and every single medication. So this was done over 2 years with 2 Master's Clinical Pharmacy students, Muhammad Zulhilmi and Universiti. We were able to collect data from 491 patients. We saw that when we were to assess them as a general assessment, medication taking, we found that from this assessment, 82.3% were found to be adherent to medication. Now, when we assessed each individual drug separately, we found that this adherence level dropped to 27.5%. So you can see that if you feel like your patients are adherent to medication, they actually may not be, because when you're looking at each individual drug, you know you're going to have some drugs that they're going to have problems with. So the details of the study will be discussed and explained to you by Mr. Universiti in the next session. But this is something that I think everyone should take note of, the fact that when you're assessing individual adherence, it drops drastically. Just goes to show that there's a lot more work still to be done among CKD patients when you're looking into individualizing medication. Having done that, we found that it's actually quite difficult to get patients to tell us whether they were adherent or not towards each individual medication, because it can be quite, they can be quite defensive. So we wanted to find a way for us to actually be able to predict the level of adherence towards each individual medication. So we extended the study to include 1,012 patients and used 2/3 of this study population to actually develop a score. So based on this 2/3 of the study, 677 patients, we found that the factors that affected adherence towards medication, each medication taken, was basically patients with 7 or less medications, 3 or less comorbidities, not using CAM, and if they had a medication knowledge score of more than 80%. So medication knowledge score was basically assessed using dose, frequency, indication, and whether or not they knew how it was administered. So if they scored more than 80%, this showed that they were actually adherent to all medications, and this medication knowledge score was done for each medication. And we used this logistic regression and the beta values to come up with a score with a total score of 7. So a higher score indicated better adherence. So, okay, don't worry too much about the graphs, but just very briefly, anything above, any curve above this particular line shows that the outcome is positive, and it was correctly predicted. And so this is the original graph to show that the multiple logistic regression was able to predict adherence correctly, and the scores that we developed were also able to correct the outcomes of adherence quite well, which is similar to the original graph. So there's no difference between these two, which shows that it's good that the score that we developed was true to the original information. Now, in 1/3 of the data, we use this for validation using the scores that we produced. And again, you have a similar graph. You look at the top and the bottom of 1/3 of the study population. It was able to correctly predict adherence. This is the original data. And the bottom one is basically using the scores that we developed in 2/3 of the data. Again, you see a similar pattern in terms of the graph. So what this shows basically is that the score that we developed was able to predict medication adherence of CKD patients, taking into account each and every medication taken by that particular patient. So this score is something that can be used to predict adherence of all the medications using these particular factors, bearing in mind that you've got to actually measure the level of knowledge for each drug. So these kinds of help you to get objective answers from them without them feeling very defensive. So any level any level lower than 3.5, so in this case there's nothing that's scored as 0.5, so anything lower than 4 should be given greater attention, because there's risk of non-adherence with the patient. So this is something that I think that can be quite useful for pharmacists to use if you're assessing patients on CKD medication. And from the study population, we were actually able to look at the level of adherence towards different classes of drugs. And here, if you look at this table under study population, don't bother about the development and validation cohort. This is basically a table to show the number of patients that are adherent to each class of drug. You'll find that they were least adherent towards phosphate binders, insulin, as well as oral hypoglycemic drugs. Basically, only 50% of the study population were adherent to these drugs. So again, you've got to look into reasons why they weren't adherent to these drugs. Was it because it's something that they didn't bother taking because they didn't know the significance of it? But basically, in this study, we found that phosphate binders were the least adherent because of the taste, and having to chew it kind of made the food they ate not as delicious, and that insulin was a problem because a lot of them had problems having to poke themselves with the needle. So, having to address these issues individually will probably help improve the outcome of the patient. And this lack of adherence would probably translate into changes towards doses, which further complicates medication management. So the next thing we want to look into is how often were these drugs adjusted. Obviously, we couldn't find out what the cause was, but we wanted to see how often were drugs adjusted over a period of time. Adjustments to medications is something that you're often seen with patients on lifelong treatments, such as chronic kidney disease patients. And this is something that we wanted to look into a little bit more detail. How often were drugs adjusted over time? So we were able to then recommend ways to actually optimize the outcome, especially if we're looking into individualizing therapy. We wanted to know which drugs were most adjusted so that we can address this amongst CKD patients. So you can see that the most common drug when it comes to adjustments is actually antihypertensives, and we know that antihypertensives are used to control blood pressure because this reduces rapid kidney progression, and it's also used to actually reduce proteinuria. So obviously it's something that probably requires optimization every now and then. And as you can see, over a 2-year period, out of 671 patients, this was the most adjusted medication. So the total number of adjustments for antihypertensives was 948 times over the 2 years. So this is quite alarming. We've also seen that insulins were also quite often adjusted in the patients. And if you think back about the adherence, this could have led to non-adherence or could be the cause of non-adherence. So when you're individualizing treatment for CKD patients, all these have to be taken into account, and therefore, sitting down with the patient and understanding what their problems are needs to be done for each CKD patient so you can optimize them accordingly. Now, phosphate binders are other drugs, which comes up as the fourth type of drug which required adjustments, which kind of makes sense because you can see that most of the patients didn't really adhere to phosphate binders anyway. So having identified that the antihypertensive drugs were the most frequently adjusted, we wanted to know what the factors were that affected antihypertensive adjustments. Obviously, if you're individualizing drugs, you want to really understand reasons for the changes. It's probably not going to tell us if it was due to this that changes were made or as a cause of, but at least gives you an idea of what to focus on when you're looking at patients on antihypertensive drugs and wanting to individualize their drugs. The best thing to do, obviously, is to do factors associated with each particular drug, which is hopefully something we can do in the future. So this is based on part of an FRGS grant, and what we found was that the factors that factors that was associated to drug adjustments for antihypertensives were an increased number of follow-ups from various institutions if they actually visited more than one institution, which is quite interesting. If they used traditional or complementary medicines, if they were poorly adherent to that medication, so this kind of links to the previous study, and if there was a higher degree of albuminuria. So these are things that you may want to look into if a patient comes to you with an adjusted antihypertensive drug, so that you're better able to understand what it is that's leading to it, or maybe the cause of it. So when we looked at each antihypertensive drug individually, we found that calcium channel blockers was the most frequently adjusted over the 2-year period, followed by ACE inhibitors. So a lot of these patients were actually on CCBs and ACE inhibitors. You'd expect them to be mostly on ACE inhibitors and ARBs, but to be fair, we don't know at what point we're actually looking at this patient, and because they're mostly towards middle or end stage renal failure, they may have already been on ACE inhibitors and have adjusted their ACE inhibitors and ARBs to a point where now it's the CCBs that they're working on, and we didn't look into whether they have proteinuria or not, which could also affected the choices of antihypertensive. But in general, the most often adjusted drug, whether it be added, stopped, increased, or decreased in terms of dose of frequency, was the CCBs. So again, close monitoring with pharmacists is recommended in that particular case, and finding out what really is the cause of these changes is something that we really need to look into to make sure we understand what the problem is when it comes to medication taking, and so that we address individual medication management in CKD patients. We did further analysis on these patients and found that 18% had further adjustments to their medication, antihypertensive medication, following their initial adjustments, and the most common reason was because of ADR and uncontrolled hypertension. And to give you a clearer picture, this was just done over 2 years. Most of these patients actually take this lifelong. So you'd see further changes over a longer period of time. We also found that there was a significant correlation between antihypertensive adjustments with other drugs, such as the most strongest correlation was actually between anti-diabetics or oral hypoglycemic agents, as well as diuretics. So all these have to take into account when you're looking at changes to medication. Kind of helps you understand further all these different things that are happening in CKD patients when they're actually managing their medication, and helps you look into individualizing or personalizing their treatment based on their lifestyle and their needs. This hasn't taken into account yet the genetics of the individual, which is something that we're also interested in looking at, and which I'll talk about after this. There's a lot of interest when it comes to pharmacogenetic studies, and the most common being CYP450 metabolic enzymes, which affects more than 80% of drugs that are prescribed. And the most common of this CYP450 was the single nucleotide polymorphism of the CYP3A5, which occurs in about 70% among Asians. And there's been various studies to show associations, and significant or otherwise, with CYP3A5 and medications taken by Asians. So we want to look at Malaysians, and specifically in CKD patients. When we looked at the effect of CYP3A5 polymorphism on progression of CKD, we found that when it came down to alleles, they'll look at this as CYP3A5 star 1, which is the wild type, and star 3 is the polymorphism. You'll find that at baseline there was no difference. When you go down the table after 3 years, there was a significant difference in which patients with a star 3 variant of the allele had a higher number of decline from A2 to A3, and this was a significant decline from A2 to A3. And when you look at genotypes, you've got homozygous, where you have a wild type. You have heterozygous, when you have a wild type as an SMP and a polymorphism present, and homozygous when both alleles polymorphism are present. And you can see that in terms of baseline, there was no difference in baseline EGFR at the start of the study. And after 3 years, you can see that homozygous patients had a larger decline in or a lower level of EGFR, which was significantly lower than the homozygous and heterozygous genotypes. And when we looked at baseline albuminuria, there was no difference in terms of the level of baseline albuminuria between patients at baseline. And after 3 years, you can see that there was actually quite a significant change in which patients with the heterozygous, where the SNP was present in one allele, a lot of these had actually moved on to A3, had progressed to A3. So here we can say that there was actually a significant effect of the presence of CYP3A5 polymorphism on progression of chronic kidney disease in our study population. We then looked at factors associated with rapid CKD progression, just to look at whether CYP3A5 polymorphism played a role in rapid CKD progression. And rapid CKD progression is basically defined as more than 5 mL per minute decline per year, and this was done over 3 years. And we found that age, younger age, was a factor for rapid progression. Adjustments to hypertensives, CYP3A5 homozygous polymorphisms present was basically a factor. Dyslipidemia, being a current smoker, and those that actually used a TCM. So all of this are important findings in the fact that you can take all this into consideration when you're actually counseling the patient, talking to the patient, finding out why CKD seems to be progressing in your CKD patient. Another thing that I think I want to highlight here is the use of TCM seems to come up when it's to do with adherence as well as rapid CKD progression. So again, this is something that I think we should address among CKD patients, and we've got to find a way to get them to actually tell us whether or not they're using TCM, because we can ask them what TCM they're using, and if it's something that's not going to benefit the patient, we've got to find ways to actually approach the patient in a way that's tolerable to them, to get them not to use TCM. So anyway, going back to genetic factors, quite interestingly, CYP3A5 polymorphism or homozygous CYP3A5 seems to be a factor with rapid CKD progression. So genetics plays a role in CKD patients as well. So more studies need to be done. At the moment, what we're doing is, I think we're looking in 2D6 and C19 and finding out whether these have effects on the patients as well. All these are polymorphisms, SNPs that are quite common in Asians, and so we're looking into those as well under the same grant, and we have a PhD student going down looking at these other genes to see whether this affects patient outcomes in CKD as well. So in conclusion, there's still lots of work to be done when it comes to understanding medications and CKD patients and how to actually individualize these drugs. We've only managed to do studies on antihypertensives, mainly because these were the ones that came out as the most often adjusted drugs. We're working on other drugs and other medications, and we'll share with those once they come out. We're also looking into further genes, other genes, the most common genes among Asians being 2D6 and C19 under the FRGS grant. And we're happy to show and share these results to you at a later date. But at the moment, what we can do, based on the findings we have right now, is to actually address changes to medication adherence and adjustments among CKD patients, trying to find out why they're not adherent to specific drugs and managing them accordingly based on the patient's individual lifestyle, environment, what the problems are, and why certain drugs are adjusted quite frequently. If there is a way for us to actually reduce the risk of or the times drugs are adjusted, this might help improve adherence towards drugs. The prediction score is something that would be interesting to use in the setting because it allows us to actually address adherence of each individual drug, whilst not asking if they were adherent to drugs. So this is something that could be helpful so the patients don't feel defensive and we're not worried about whether they're being honest or not. So you can just ask them some very objective questions if they know the drugs, and then look into their risk factors such as number of comorbidities, number of drugs, whether or not they're taking CAM, and predict whether or not they're going to be adherent to medication or not. This could be used to ensure that there's persistence towards taking the drug among CKD patients. So in a nutshell, individualized medication is required for CKD patients. We've done studies to show that individual adherence differs quite drastically when you're looking at each drug compared to when you're looking at the whole drug taken among CKD patients. We need to look at patients who are smokers because, this factor seems to come out when it comes to adherence, when it comes to genetic factors, rapid decline in kidney progression. You've got to look at how often or how many different types of institutions they're visiting, because this seems to affect the number of times a drug is adjusted, whether the clinician or a pharmacist from one institution is aware of this. This might actually help us reduce the number of adjustments made. We've got to look at their knowledge. Probably improving their knowledge could also improve their adherence. This is something we have to look into too. We know that knowledge predicts individual medication, and knowledge already predicts their individual drug adherence. So we want to know if improving knowledge could improve adherence as well. Genetic factors are something that we could look into. This may take a little bit more money, but it's worth looking into whether or not they're taking CAM as well as their age. All these are drugs that are factors that we have to look into, that we have to address when we're actually individualizing medications for CKD patients. So with that, I thank you, and this is my email address. If any of these research interests you, you can always email me at this address and I'll be happy to share the full paper with you. With that, I thank you.